Thank you, Mino. I'll quickly share with you, my experiences and how we can do safely posterior polar. So many of the times, it is documented at posterior polar, but it may not be a posterior polar cataract. So not all which have that kind of central opacity may be posterior polar, but there are different ways to identify. There is a dehiscence before you can identify. Onion world-like appearance gives a clue. A cortex sunken sign gives a clue. And recently we published a very good work on doing ASOCT on some of these eyes, and we have documented that ASOCT can help to some extent. But still, any case where you see like this, you need to be careful because there is a high risk for a PC rupture to happen. It can be a thin area or it can have a dehiscent area. And there is a kind of opacity which is there finally. Once you remove that opacity, you can cause a dehiscence. And additional surgical challenges are many of these patients may have very soft cataracts because they are quite young, and nucleus rotation may become very, very difficult because you can't do hydro procedures, and they have visually significant cataracts, so challenging also. They have significant, their quality of life is affected, but at the same time we need to make sure that they undergo this procedure without complications. So I think for PPC, I think I recommend these three PPC, again, very important: planning, procedure, and also preparing the patient, telling him the risk of surgery, any multiple procedures or any additional VR procedures, and also trying to prevent a PCR happening where there is a thin area. If it is already a dehiscent, you have to be very, very careful not to drop anything inside for another procedure, and also choosing an appropriate technique. So I won't go into detail, but this is so important. You need to talk to our patients, take some chair time, and tell them what is the problem. Don't take them like a regular phaco. When we talk about anesthesia, I think it's so important. Whatever anesthesia you're comfortable, even topical we can do, but young patients, if they are apprehensive, if you think they would definitely have a dehiscence, I think ideally it's good to have some kind of anesthesia. I would recommend something like a peribulbar, retrobulbar, even a subtenon's anesthesia, without much damage to the conjunctiva. Procedure of choice again would be an phacoemulsification. Very rarely, people even do lensectomy when they have a big dehiscence and already the cortex is sinking, people can do. But the most important tips to keep in mind is before the incision, you make the side post first before the main incision. So you avoid over pressurizing the anterior chamber with viscoelastic, and again, heavy viscoelastic young patients to counter the scleral elasticity. You always use high molecular weight and heavy viscoelastic into the anterior chamber, and then you create your main incision. So rhexis is important, but size of rhexis is equally important, because if you're making too big the rhexis, again, placing the lens in the sulcus may become difficult. If it is too small, again, manipulating the lens without any hydro procedures may be difficult. So ideal rhexis is important. And if there is a kind of a PCR occurs during the hydro, the nucleus is more likely to prolapse into the anterior chamber through your rhexis. And it's easier to manually prolapse the nucleus in the anterior chamber if PCR occurs, if you have a ideal size rhexis again. If it is too small, again, it may be difficult to prolapse. And the second point I insisted even before. This dissection delineation is again a dilemma. It's a hydrodilemma. So basically, you want to do a cortical cleaving hydrodissection normally, but here I think it's one thing which is contraindicated. Ideally, you have to delineate, but it's sometimes delineation may not happen as delineation. The fluid can go and dissect also. So you have to do a very careful delineation. And any vigorous decompression of the capsular bag after delineation should be avoided. And don't try to rotate the nucleus like normally how you would like to rotate. So this is one technique, again, recommended by Dr. Abhay Vasavada. He has published this also. I do this in most of my cases. It's called inside-out delineation. So this is to avoid a hydrodissection to happen when you do a normal delineation. Normally, you delineate after a rhexis, you try to get inside into the nucleus. Whereas here, you make a small trench, and through the trench, if you do delineation, the fluid will go only between the endonucleus and the epinucleus. So it will not go over the epinucleus. So if it goes over the epinucleus, it can increase the dehiscence. And this is very important. Everybody would insist on this. If you're doing cases like this, you have to do a slow motion phaco. All your parameters have to be low, including your power, your bottle height, your aspiration, vacuum, everything you have to do in a slower mode. And there are different nucleotomy techniques. There are different techniques reported, but there are techniques which you are comfortable. Normally what I do is I try to trench. After the delineation, I try to trench, divide the nucleus into two halves, and then lift the heminucleus, kind of crack and then lift. So you have to divide. You can crack it. You can either chop it, or you can do like a 4-quadrant cracking, and then you can lift the either nuclear halves and then emulsify, because many of these cases are not very dense. But if it is very soft, again, this technique would be difficult to do. So ideally, in situations like that, you have to really modify it. But this will be an ideal option to just crack and then lift the two halves. In harder nucleus, again, you need to phaco chop, but without rotation, you have to gently remove some of the nucleus and then try to chop the rest of the nucleus. So this is a very popular technique. Wherever already you see a dehiscence, this is the way to go. You have to do layer by layer phaco. I'll just show you a case, which you can see a beautiful dehiscence here, which I did a couple of weeks back. So there is a pre-existing dehiscence. Here you need to be careful, because you can't extend the dehiscence. At the same time, you don't want to lose the lens material anywhere. So here I'm not even doing any kind of dissection or delineation. With a very low parameters, I'm just trying to do a layer by layer phaco. Here trying to remove gently the nucleus, little bit of endonucleus, and then you have to just lift off the endonucleus 360 degree using your second instrument without rotating the nucleus. So once you remove one part of it, the nucleus, and then the next part of it will be the epinucleus and the cortex. So anywhere when you're coming out like the other speakers, again, I would insist that you cannot allow the chamber to collapse here, because this dehiscence will automatically enlarge and you will have vitreous. You need to push in high molecular weight viscoelastic before you do any step. So the hydro has to be in place, and then inject viscoelastic before you remove the hydro cannula. Whenever you're switching hands or doing any step, don't allow the chamber to suddenly decompress. And it's so important, you have to be very, very gentle and then do layer by layer and also clockwise by clockwise carefully, because that is where the dehiscence is there. You don't want to enlarge the dehiscence. In spite of all this, there is a slight enlargement if you see on the lateral side, but fortunately no material was lost. Whenever you remove the last plaque, you have to be very careful. And finally, the lens here, I'm trying to put a 3-piece lens. So it's so important that you need to keep a backup lens in these cases. You just can't go with one lens here. You need to have a backup lens, and that lens has to be a 3-piece lens. So ideally a sensor lens you use, and finally I'm using a myocol to constrict and make sure there is no vitreous. So this is one best way where you already have a dehiscence. If you have a documented dehiscence or you have a dehiscence, it's good to do a layer by layer phacoemulsification.